From my side, I am ready.
Just go ahead. First of all, on behalf of Dr. Reddy's family, I welcome Dr. Rizal Hamid from Banbeta, is a renowned psychiatrist from this territory. And today we have the session on the mixed anxiety and depression disorder. He will share his experience and clinical practices which he is doing since many last few years. So with this, doctor, I handed over the session to you. You can start now. The session is over to you, sir.
Thank you very much. First of all, my warm regards to all those participants and my heartful thanks to the organizer for having been given this opportunity of interacting with such a esteemed audience. So today I'm going to talk on very common, very crippling, very disabling and very weird form of mental illness. Phenomenology of this illness and the entity of this illness is still under debate. What we can see in the fourth edition of DSM or the fifth edition of the DSM or 11th edition of the ICD, we can see huge changes in the entire conception of this very complex form of mental illness, and that is the mixed anxiety depression. This is the entity I am going to talk on is the mixed anxiety depression, and sometimes what is seen is that this entity usually remains under the diagnostic threshold, and sometimes in the scenario that it could be depression predominant or it could be anxiety predominant. So when the symptoms of anxiety both are present and neither of the entity is clearly predominant and neither type of symptom is present to the extent that justifies a diagnosis to be considered separately, and most of the time it remains as a subclinical state, and it is seen that whenever the person is subjected to some stress or some life events, then they end up with very serious form of conditions, either of the anxiety spectrum or of the depressive spectrum. So ICD-11 describes this mixed depressive and anxiety disorder as the symptoms of both anxiety and depression are more days and not for a period of at least for 2 weeks, and depression includes the depressed mood or markedly diminished interest or pleasure in activities, and there should be multiple anxiety symptoms which may include feeling of nervousness, living on the edge, not being able to control worrying thoughts, fear that something awful will happen, and having trouble in relaxing, muscle tension and sympathetic autonomous activity, and all those anxiety symptoms. And most importantly, neither of these sets of symptoms can be considered separately or is sufficiently severe, numerous or persistent to justify a diagnosis of another depressive disorder or anxiety or fear related disorder. And these symptoms result in significant distress or significant impairment in personal, family, social, educational, occupational and other areas of functioning, and there should not be any history of mixed episode or manic episode, and it should not be suggestive of any bipolar disorder lying beneath. This is a very interesting slide that I am sharing with you. Here I am talking on differentiating the anxiety symptom and the depressive symptoms. In anxiety, what we can see, in case of anxiety, people used to get adapted. But in depression, the symptoms becomes very debilitated. And anxiety, the worries are future oriented. The patient thinks about worried about the future, and in depression, the person ruminates about the past. And helplessness is mostly seen in anxiety, and in depression, hopelessness is seen predominantly. And most importantly, in case of anxiety, the symptoms are worsened in the evening, and in case of depression, the symptoms worsen in the morning. And in anxiety disorder, patient used to blame some external factors for whatever negative is happening in his life. But in case of depression, he blames the internal factor, that is the self. He blames himself for whatever is happening with him. And if we see the variation of the sleep disturbances in anxiety, we can see the trouble in falling asleep. But in case of depression, what we can see is the early morning awakening. So these things are very important in diagnosing and differentiating these symptoms. And in anxiety, there is also a potential risk of suicide. But in case of depression, the risk of suicide is a definite condition. So we can see that there are lots of symptoms that overlaps between anxiety and depression. If we see the purely anxiety symptom, those would be the anxiety, feeling of anxious, worry, dry mouth, the palpitation, sweating, trembling, blushing, stuttering, what we can see mostly the autonomic symptoms. But in case of depression, we can see mostly the moods would be depressed, will be getting anhedonia, that is the lack of loss of interest in previously pleasurable activities. We can see appetite disturbances, so patient would be feeling worthless, there will be suicidal ideation, there will be low self-esteem. So these are the symptoms of the two poles. But there are some symptoms which are predominant in both the condition, both in anxiety and depression, and that makes the picture very blurry. And those symptoms are psychomotor agitation, irritability, fatigue, difficulty in concentrating, sleep disturbances, muscle tension, GI complaint, pain, and these symptoms are seen both anxiety and depressive symptoms. So here I am going to elaborate about the depression and anxiety, the global burden of the disease study, the global burden of the mental disorders across India, data of 1990 to 2017, and the picture is very, very worrying. We can see is 10.7 crore people had mental disorder in 2017, and if I go to comment on the actuality of the actual data would be much more. And of these 4.5 crore people had depressive disorder and 5 crore has anxiety disorder, and this 5 crore of anxiety disorder is the 4.7% of the global burden of the disease, and its contribution to the mental disorders to the total disability adjusted life years. 2.5% in 1990, which became 4.7%. And if we check the other mental health entities, that we can see is that depressive disorder, it accounts for the 33.8% of the burden of the disease. Anxiety comprises 19% of the burden of the disease, and idiopathic developmental and intellectual disability, the entire spectrum of the mental disorder, autism spectrum disorder, and those comprises 10.8% of the burden of the disease. And schizophrenia, we can see 9.8%. Schizophrenia imposes 9.8% burden of the global burden of the disease study in India. And these facts and figures are very worrisome and very terrible. So here I am going to show you the pandemic impact of this anxiety and depression. We can see in this slide during the pandemic period, we can see the spikes of anxiety and depressive disorder. So the effect of pandemic has significantly shown increase in anxiety and depressive spectrum of illness. Here I am with the risk factors. So there are so many risk factors of this entity, this mixed anxiety depression, and these risk factors are very important, and we need to comprehend these risk factors, and this is also associated with our treatment planning. So before we plan the treatment, we should know about these risk factors, that is, having a familial history of mental health disorders, including substance abuse and poverty and financial constraint. These are the very strong and important risk factors. Lacking the family or social support, having a serious or chronic physical illness, person suffering from low self-esteem, and various form of childhood trauma, actually the sexual abuse. That we have to deal with the increased amount of daily stress and old age, and all these conditions makes a person vulnerable to develop this condition. Here's a study published in British Psychological Society. It says that mixed depressive and anxiety disorder is a clinical rather than subclinical, or more than anxiety or depression in general population. What in actual more people are suffering from this condition. Here I am with the key clinical recommendation. So clinically it is recommended that we have to consider the broad psychiatric diagnosis when assessing a patient with depressed or anxious mood. And as misdiagnosis is very frequent and negative effect outcomes, and we have to make specific and appropriate reference to specific forms of psychotherapy such as interpersonal therapy, cognitive behavior therapy, problem solving therapy, and we have to provide the key educational messages at the beginning of treatment which can enhance the treatment adherence and compliance. And we have to monitor the treatment adherence from the very early period of the treatment initiation, and we have to also look for the treatment response and possible side effect of various medications that we can opt for. And we have to treat depression until full remission in order to decrease the relapse, and we have to keep the patient under vigilance, that is the regular follow-up to look for whether the symptoms has relapsed or he fully under remission or not. And we can change the treatment protocol after 6 weeks when there is no or very minimal response to the initial medication. Then we have to evaluate every anxious and depressed patient for any alcohol or other form of illicit drug abuse. So there are so many treatment options for these conditions, and we have very classical antidepressant. Those are the tricyclic antidepressant, TCS, like amitriptyline, imipramine, nortriptyline, or we have SSRI like fluoxetine, sertraline, citalopram, etc. And we have SNRIs like venlafaxine, duloxetine, or desvenlafaxine. And we can also go for atypical antidepressant like bupropion or mirtazapine. And simultaneously, these are for depression, and for anxiety we can choose benzodiazepines like chlordiazepoxide or alprazolam, or azapiron like buspirone, which is purely anxiolytic, mostly acts on anxiety. Here I would like to highlight a very salient point, that this azapirons like buspirone, which is available in India, is purely anxiolytic. So it will not be having any antidepressant effect. Likewise, in our antidepressant basket, say for example bupropion, so this is purely antidepressant, and it is having very minimal or no anxiolytic effect. For anxiety, we can also go for sedative antihistaminic like hydroxyzine, or we can go for beta blockers like propranolol. And most importantly, simultaneously with these medications, we should go for cognitive behavior therapy, interpersonal therapy, problem solving therapy, and if required, ECT is also recommended. Here I am coming with a fixed drug combination treatment, that is called FDC, that is the fixed dose of chlordiazepoxide and amitriptyline, and we'll be exploring what evidences say about this combination. So as you know, amitriptyline is a tricyclic antidepressant. It acts by blocking the reuptake of both of the serotonin and norepinephrine neurotransmitter, and simultaneously it is having binding affinities for alpha adrenergic receptor, histamine 1 receptor, and muscarinic receptor. And at this point, I would like to highlight, for this point, we may have some side effect with this particular molecule, that is in old age. It can, for ACE1 antihistamine blockers, it can cause sedation, and alpha 1 adrenergic blockers, it can reduce the blood pressure, And for blocking the muscarinic receptor, we may have complaints of dry mouth, and in case of older individual with benign prostatic hypertrophy, we may have urinary blockage. And further, I would like to highlight is that for this blockage of the muscarinic receptor, there might be precipitation of glaucoma. So before we go with amitriptyline, we should be aware of this action on these receptors, which are basically unwanted and not expected. And the positive point is that the chronic use of this amitriptyline causes the increase in BDNF, that is the brain-derived neurotrophic factors, and this brain-derived neurotrophic factor increases our mood. And if I talk about the brain-derived neurotrophic factor, that is the new insight of antidepressant action. What it is can see in that basically previously it was thought that it was the down-regulation of the receptors that coincides with antidepressant efficacy, but now it is known that it is the gene expression that impart the antidepressant action. That is, the mechanism is not just restricted to the receptor level, but deep inside the cell, and that is the receptors give some signal. So some signaling mechanism is there that signals the inside of the cell, and that signal induces some genes to be expressed, and newer genes are being expressed, and newer proteins are being synthesized. Some are lytic proteins and some are non-lytic proteins, and those lytic proteins they causes the receptors to down regulate, and BDNF is the protein that is synthesized after the signal being given inside the cell to activate a new gene, the new gene activation, and BDNF is the byproduct of that process. This is called the brain-derived neurotrophic factor, and this BDNF causes newer and newer synapses to grow, and it also increases the new cell growth. As we know from our theory of neuronal plasticity, that nerve cells continues neurogeneration. It's a continuous process. It continuously keeps on occurring inside our brain. So the BDNF also promotes the formation of newer neurons, and it also inhibits apoptosis, and thereby it increases the connections, increases the overall processing power of the brain, and that's how it yields its antidepressant action. And it is to be mentioned that this amitriptyline has there is the half-life of 10 to 28 hours. It is to be kept in mind. It's very long, and it gets metabolized to nortriptyline. And if I talk about the chlordiazepoxide, we can see that it's a benzodiazepine to be used, first benzodiazepine to be used clinically. It is a smooth, long-acting benzodiazepine, and it is preferred for chronic anxiety state. And chlordiazepoxide is often combined with other drugs in psychosomatic disorder. It is having lots of efficacies. It is in alcohol detoxification. It is the drug of choice, and it is T-half is 6 to 12 hours, but its active metabolites are produced, which extend the duration of its action. This is the free drug combination versus its component. There were the two parallel double-blind randomized clinical studies with chlordiazepoxide with amitriptyline and versus amitriptyline alone in anxiety and depressive state. And what we can see is that combining chlordiazepoxide with amitriptyline is more practical, more advantageous for patients with anxiety depressive state than a single drug. Another double-blind multicenter randomized study where chlordiazepoxide with amitriptyline versus amitriptyline alone was studied, and this study also showed that the combining chlordiazepoxide and amitriptyline is more practical and advantageous for the patients with anxiety and depressive state than that of a single drug. So here you can see the another study, that is the chlordiazepoxide with amitriptyline versus amitriptyline alone. Here also we can see the combining chlordiazepoxide amitriptyline is more practical and advantageous for patients with anxiety depressive state than that of the single drug use. So what we can see is that the entity we talked about, the very elusive entity, here we can see that chlordiazepoxide and amitriptyline fixed dose combination can reduce stress and tension. It improves mood and feeling of well-being, and it reduces agitation and nervousness, and simultaneously it regulates sleep. And so overall it reduces symptoms from the very first week of treatment. This is the most important factor, important point to be noted for this condition. So thank you very much. I'm over. So my presentation is over, and I hand over the mic to the organizers, and hereby I am stopping the share.
Thank you, Dr.
So anyone if present, if they have some question, I am ready to accept it.
Thank you, Dr. Hamid, for this lovely session. I truly agreed with the way you had briefly explained all these things. Surely there might not be any questions, but though the Q&A session for at least 5 minutes. If any one of the participants having any questions, they can directly ask to Dr. Hamid, or they can put in chat box also.
Thank you so much for your time.
There is no doubt on this from any one of them. There is one question, one master class from Dr. DJ Mia. Thank you.
Okay then. Thank you very much for all of your questions here. And thank you organizer for your effort, for this type of effort for education and creating platform for us